Dr. Barnabas Alayande to the Everyday Leader. I'm so excited to have you here. We've been going back and forth planning this interview. It's been quite an interesting arrangement, to say the least. So I'm just so glad that we finally get to sit down and do this. So welcome to the Everyday Leader.
Thank you so much, Nanya. Really, such an honor and a privilege to be here. And I trust that we will be able to share some interesting thoughts as this progresses. And thanks for the
Yeah.
work you do on.
Thank you. Appreciate that. I mean, knowing you, I know this conversation is going to be good because we've met each other in different, places before this, prior to this interview. So I know it's going to be good. I'm so excited. Okay, so for the audience who don't know you, who are you? Where did your journey start? And, how did you become the man of impact that you are today?
Thank you. I would push back on Man of Impact. I think that there's still a lot more to do, and the future does look brighter. We're at an inflection point where things will be getting better and better, and influence is still opening up. But I think that there are a few things that are responsible. I'll get there. I'm Barnabas Alayande. I like to introduce myself tied to my current institution. I am currently the co-chair of the Center for Equity in Global Surgery at the University of Global Health Equity, which is a health sciences university that's located somewhere in the north of Rwanda. Some people would place it in the middle of nowhere, but it's very deliberately, very strategically placed there, so that there is a social medicine component and a community component to a lot of the work that we do. So I'm a general surgeon by training, an educator, global surgery researcher, and I run a number of global surgery programs. I lead the global surgery training across some undergraduate, postgraduate systems and fellowship programs too. My work is at the intersection of public health, health systems, surgical care, and equity. So it's spanning a lot of surgical education, trauma care, and non-technical skills, which is a lot of the work I do, and then policy-oriented research. So I trained clinically in Nigeria, maybe backing up, born in Nigeria, spent some time in the UK, came back to Nigeria, was really mobile across the country. I've lived in the north, south, east, west of Africa's most populous nation. And a lot of the lack, the needs, the exposure that I had to this population shaped me. And eventually one thing led to another. I decided to go into medical school, even though my parents wanted me to study computers. And yeah, and I
Oh,
also
wow.
had the seminary, but I
The
just
first
really,
Nigerian family to not want their child to be a doctor.
in fact, my mom in her language said, "You're not settled. You're not calm enough to be a doctor. So why don't you just move over here?" But I really had a sense in which I'd had an encounter a while earlier where my mom, as a single mom, was looking for resources to pay for someone's care for malaria. And as she's really looking, I'm talking literally searching everywhere. Do we have extra change here, there? We didn't grow up with a lot of privilege. Then my little sister asks a question. She said, "Mom, where do they make money?" And she says, the printing and minting company. She said, "When I grow up, I want to work there." But in my mind, what I was thinking is, okay, where do people who do not have the resources to get healthcare, how can they get healthcare? And so my mind was already moving in that direction. One thing led to the other. Graduated with prizes in public health, and my heart was in surgical care. And I remember drawing a map of Africa and writing under general surgery and public health. With what am I going to reach my continent? That was my heart. And I felt I had to choose. So I spent some time in southeast Nigeria, where I was the only doctor serving 19 health centers, 19 health facilities, only doctor. So I'd move from place to place, and I had people die just a short distance from where I was because of lack of access to healthcare. And I knew that I had to go back and get surgical training so that I could address some of these needs that I found. So I looked up where which was the best training institution, West Africa College of Surgeons. Then, and I said, this is where I'm going. So I packed up and went to that city. I submitted my application, even though there were no applications going in. I had to wait a bit anyway, not all that. and then and then eventually got my training at the Jos University Teaching Hospital. I spent some time too at Ibadan doing cardiothoracic surgery, but eventually graduated with general surgery. From there, I helped to develop a health system for HIV/AIDS patients, a surgical system, because at that time there was a lot of stigma and people didn't want to include them in surgical services, surgical care. So I joined a foundation, the Faith Alive Foundation, worked to strengthen surgical care for HIV/AIDS patients. And then, and then I discovered that there was the possibility of me being in surgery and still having something around public health, that merging together. That concept of global surgery was new for me, but I knew immediately I came across it that this is exactly where I'm supposed to be and this is what I'm supposed to be doing. And so one relationship to another, I went to for a fellowship, 2-year fellowship at the Harvard program in global surgery and social change. From there, I was posted to Rwanda to help start up the surgical care, the surgery department at the University of Global Health Equity, and a lot of the research that was going on there. And so we started the undergraduate surgery, moved on to start the Center for Equity in Global Surgery, moved on to start the postgraduate Masters in Global Health Delivery program, and contributed again to the starting of the residency, which we're just starting. So I think it's been a journey. There's a lot that is in it, but I think that's safe to say that this is a summary of that journey. Now I serve in a number of capacities, serving as the Secretary General of the Pan-African Surgical Healthcare Forum, which we may get to when we're talking a bit more in detail, serving as the Program Director of the Masters in Global Health Delivery, serving as the co-chair of the Association for Academic Surgery, the Academic Advancement Committee, just dotted that way. I think that I've been very privileged by relationships, by solid mentorship, by being in the right circles, by connecting with people like you and those that are within our circle, and be given a lot of opportunity. But with great opportunity comes great responsibility. And I want to honor all those in my life that have nurtured these responsibilities and these opportunities. Over.
Wow, that's amazing. Just to hear that journey. When you meet someone who has such depth, you can tell that they didn't get to where they got to just out of the blue, right? Like you had to go through different stages of life, and you're just talking about it, and you're running out of air. I can imagine the actual experience of being in those situations. And learning from them. So, and in Africa, on top of that, in the African healthcare system. So, I applaud you for the journey you've taken and that you're here today. So, I think all of the other things that you said, all the positions that of leadership that you have now, um, actually is just a proof that you have done the incredible work to get to that point. So that is very inspiring. So like you said, you're a surgeon, and a lot of surgeons wants to stay in the clinical environment, right? They just want to go to theater, do their thing, and nothing much. So you mentioned what inspired you to be a doctor, but what actually inspired you to be a researcher? You mentioned about the HIV care, HIV patient surgical care research that you were involved in. So take me in depth to that. What was the turning point that made it click in your mind that you can do research while doing surgery, but also you're now kind of almost inclined to the research and public health aspect of things. So how did that switch come about?
I think that it has been very foundational for me. Like I said, as soon as I finished med school, I was already writing public health, general surgery with what, and my thought was I had to choose. The reason being that you can stop the bleed, but you may not be able to stop the stab. I hope you understand what I'm saying. Like, if something's happening at the population level, there's a lot of influence we have in the OR of stopping what is going on right there, right in front of our faces. And it's very gratifying for us as surgeons. It's the way we're wired.
Mhm.
But the challenge is, as long as the social economic issues, as long as the political issues, as long as those high factorial issues that really determine what happens to people, as long as that is not touched, then you're just on the receiving end. And it's great. We need to be on the receiving end. That's what we were trained for. But I think that there is one step further. We have to start thinking policy. We need to start thinking advocacy. We need to start thinking right. And I finished in school with prizes in public health, community medicine, and so I already had a strong theoretical foundation showing that it's not just about the single patient, right? You have to think beyond the patient to where the patient is coming from, to what is responsible for that, to why did this patient present late. So those thoughts, every time you sit in front of a patient, you actually need to think beyond that. And for me, it was that 1 year of going into the wild. Let me tell you the story in a little more detail. So in Nigeria, you always have 1 year in which you do national youth service. It's a paramilitary service, right? So you go, you're crawling under all those wires, you're rolling in the mud, you're climbing up all the obstacle courses, waking up at 5 a.m. And then standing in your shorts in the cold and parading and all that. So platoon. So it was that 1 year of paramilitary service. And in the lead up to this, I'd done my house job. If you finish with prizes in the university, you have a direct house job. You don't have to write interviews with the teaching hospital, big teaching
Okay.
facility. But I said to myself, I need somewhere that I will not just be chasing results around and following consultants. I needed somewhere where I'll get hands-on experience, right? Solid work, surgical work. That was my inclination. And there was this place that one of my mentors had gone for service called the Baptist Medical Center of Bomosho, where he had gone to do some work. I mean, general practitioners, solid in their surgery. They were doing all sorts of things. They could do prostatectomies, and there would be little or no irrigation. They had high-level techniques. And so I decided to go. Um, but the downside was I would get like 50% of the salaries that others would be getting. And my professors looked at me and said, "You are academic material. What in the world are you going there for?" But I needed something hands-on. And so I go there. I spend a year first on call, learning C-sections, doing a number of surgeries. Like I was prepared. And so I'm posted to this place in the southeast, and I'm not the first doctor on camp. The first doctor on camp becomes the chief medical director. So I hope I'm not boring with stories. So I get to the camp and I'm told, "You're not the first doctor. Okay, we have somebody else." And there's an accident of people coming. They have a motor vehicle collision. People coming to camp, and so they bring them in bleeding, hurt. Everybody else is looking. They're just 1 year out of med school. Everybody else is looking, not sure about what to do. But I'm jumping in. I'm suturing. I'm cleaning out. I'm doing. They said, "You're our CMD." So they made me the chief medical director. Now,
Wow.
there are issues of integrity too, because as the chief medical director, you could help with relocating people. And this at a public health level. When they come in and people are not comfortable being there, they say, "I have this illness or the other." You look at their letters, you examine them, you tell them they're relocated. Well, I just got my license. I'm straight as a fiddle. I can't tell you you'd have what you don't have. So I was on that committee and it's like, no, 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 no. And a general's daughter, and it's a paramilitary camp. Military guys are the ones training you. A general's daughter is brought to me and the military guys say, "You need to say that she has XYZ so that she's relocated." I said, "No, I just got my license. I can't do this." So I said, "I'll examine her. Whatever she has, I will write, but I can't just say she has this." So I checked. She didn't have what they said she had. She had something else, but what kind of shaped something or the other. And so I was posted now, maybe in response, maybe not. I was posted to a place where there was no electricity. There was, for 10 months I was there, no electricity. There was no water, no pipe-borne water. We used to fetch water from a spring, right? I was pushed to the middle of what some would consider nowhere. Now, on getting there, instead of feeling sorry for myself, I began to see needs. And so parents were upset, mom was upset. She's like, "Come." Her friends were saying, "Come, we'll just talk with people in government." She was in government at the time. I said, so I came back and very carefully laid it out for them. I said, "I'm seeing need. I think this is an opportunity for impact. I think, I said I'd like to go back. So I just dodged the situation and got back there. And that's when I began to see healthcare at scale, practically. And began to see that it's not enough to just care for someone in the clinic. There are things that lead them there. There are issues. And I wrote some memoirs called Wavy Lines in the Red Sand. Red sand because there's bleeding, that there's death, that there are things that you probably should not happen that are happening because of the at population level. It's driving the statistics that we're seeing. Um, One thing, other stories. I was threatened in that place. I had somebody waiting for me outside the room with a gun because they wanted me to, in my position as a doctor, sign for double amounts than what I should take, and then they would split the money. I said no.
Oh my
I
gosh.
walked out. That began to show me that society is
Mm.
more than your OR, more than your clinic. There are loads of things that feed into the poor healthcare people experience on policy levels, and so I still had that stamped in my heart. And so that actually is what was multiplied, amplified, so that as soon as I saw that there was an academic discipline in that I could have influence at this level and still touch policy, still touch advocacy, still use research, begin to expand the possibility of people getting healthcare. Remember that question, what can we do for people who do not have access to healthcare? It's more than just becoming a doctor. It's also thinking of what you can do in terms of changing things at scale. So that really, those are points on my journey. I can't say like a a plane wants to take off. It's not one light that's on the runway, right? There are multiple lights on the runway that kept guiding me in this direction. And then seeing, the influence of mentors and mentorship has been a strong contributor to my life. People like Robert Riviello, who's the head of the director of the program in global surgery and social change, Professor Abebe Bekele, who's my principal. I used to sit with him and exchange ideas virtually every Friday around the COVID point. So it's thinking about what can be done to move things at scale. So a lot of things that have been birthed in my heart, a lot of the opportunities that I have, is really taking those experiences and using it to guide where I am now. And then I know that not many people talk about this, but a lot of things in our lives also driven by things that we can't compute, right? So my faith, for instance, the people that are around me, all those things feed into my thought system. I have a postgraduate diploma in theology, and then I've got a master's in public health, master's in business administration, got fellowships in in a number of colleges, three continents. So that kind of rounded education, teaching, training, and exposure, I think really drove me to understand like Paul Farmer and Jim Kim, their paper Beyond the OR. These are people who are not surgeons, they're internists, and they were thinking about Africa. That, by the way, that concept of surgery being the neglected stepchild was particularly reflecting on Africa, right? It was from a reflection concerning Africa. So it's those kind of materials, thinking and seeing the statistics, seeing the thoughts that have been lights along the runway that have driven me in this direction. Over.
Wow, amazing. So many things. There are so many things I want to ask you about that, but we'll just keep going. So, as a researcher, we have a huge set of data in Africa. Just one, we have a huge population, right? And it's the one of the highly rapidly growing population in the entire world is based in Africa. Um, but when it comes to impact of journals that we have, and I'm asking you this because you are very deep into this area of public health and research and things like that. So when you see the index of our journals, they're not quite high, even though we have the largest population, even though we have most of the disease burden, we still not high index. So how do we make sure that our research outputs go beyond just data and numbers and are seen by many, cited many, because it's about citing, right? When journals are indexed high. So, how do we make sure academics are accessing them, especially people or professionals based in Africa, to effect a change, to effect if whether it's a systemic change, policy change, or just a change in practice or adopting a new protocol?
Yeah. Thank you, Ananya. Don't get me going. But I really think
I want to
that
get you going.
I really think we need to question the premise of impact. I'm sure the data is out there. There's a lot that talks about impact factor and then the questions around it. But why do we call a journal high impact? I mean, we have to go back to the drawing board and start to ask ourselves, particularly from an African perspective, whether this impact is really what we're talking about. You see, there's epistemic injustice such that people produce knowledge as if this is the only way that we can produce knowledge. This is how knowledge should be produced. This is how it should be appreciated. This is how it should be. And we need to get to a point where we start to ask ourselves the question, does this really matter? Many academics I have met are very deliberate about, and that's how they get their promotion, about putting their work in high impact journals that in some instances cost them $7,000. We won't get into that, 7,500. And what is Ananya? So what is predatory and what is not? Is that not predatory? Don't quote me. But the thing is, African surgical knowledge should not just be produced, it should be valued, it should be
Mhm.
visible, and it should
Okay.
create influence locally and globally. So whether or not that reflects in an impact factor, I think that is yet to be seen. So if we're talking broadly about impact and strengthening continental journals and work, we can start from there. But I think the underlying issue is the equity. What's your mother tongue, Ananya? What's your
All right.
original Amharic? How many medical journals are in Amharic?
Oh, almost none. Maybe like a handful, if I can even think of.
If,
Yeah.
if if I push it further, how many surgical journals are in Amharic?
Oh, that's easy.
Oh,
0.
zero, right? So knowledge is produced and shared in a language that you are not core nature. You speak great English, yeah, but that's you. There are many people who are great scientists that the key barrier to their exposure is language. Right, the great publication in PLOS Biology that you'd see a track, something like a track, and then multiple hurdles between people whose second language is English or whose third language or fourth language is English. I think there's so many barriers there. And so the equity issue, just keep that in mind, that the foundation of all I'm talking about is that there is an inequity in knowledge generation. There's an epistemic injustice, even in the understanding of knowledge, in the interpretation of knowledge, and in who gatekeeps knowledge. Right. So if you don't have money, you can't be a
Mhm.
high cited researcher, right? Because you have to pay. We did the averages. Some of our colleagues did the averages in program. It's about $3,200 per paper you need to submit, right? And the question is that really the cost of taking a piece of paper and putting it online? So if if our now let's get back to our research. If our research, African research, only produces number without meaning, then we're failing our communities. Right? We're making a mistake. We're not being clear. If all we're doing is just, we have to begin to prioritize usefulness. And I must say, usefulness may not be equal to highly cited research for
Mhm.
Africa. If it is useful for Kigali, then only people in Kigali may want to cite it. It may not go viral, but it becomes useful. For instance, we did some work in Ethiopia. Professor Abebe, others was with the team, just looking at gloves, surgical gloves. And after he had done some work and saw that surgical gloves, this high perforation rate post-operatively. So you could look at that and just sit on your hands and say, "Oh, it's okay." So, but we said, could there be a problem with gloves that are even ab initio imported into the country? Could that be a challenge? So just went and grabbed gloves from all over, put some dye in it, put some fluid in it, and then found that in for a particular brand, 10% of the gloves were already leaking before using. Now, so
Wow.
what do you do with that kind of knowledge? How many people are going to cite that kind of knowledge? So Initially, we were looking for some big name journal and said, okay, let's put it here, let's put it there. But we sat down and said, look, it doesn't make sense. Who is it for? It's for Ethiopia. What is it? So we put it in an Ethiopian medical journal. You can find it there. We sent messages to the Ministry of Health. It went directly to them. They stopped certain gloves from being imported and used. That, my sister, is impact. So it's not. First, it must be useful. And the question is, what I'm putting in a journal that is international and hype, is it better for me to put it in some local journal that probably is not yet PubMed indexed because it would be more useful there? So we have to think about that. And then we now need to stop. We've been baselining for a long time, since 2015, as Africans, like, thinking about our surgical planning. But we need to go beyond what is the prevalence to why does this matter? Why does this work? What should change? And so we're talking more implementation science, mixed methods, even though it doesn't look as beautiful. That, oh, we like the numbers. We need to start thinking qualitative, and not just. And now let's go back to the journals. African journals should begin to not just reject manuscripts, but start to mentor authors. Start to think about how to. Sometimes I'm with a number of. I'm on the editorial board of at least 3 journals, 2 of which big time journals, high level, high impact factor that is in the double digits, right? One of them, the other is something more. One is an African one that is not yet PubMed index, but I work with the researchers there. In fact, on some occasions I've gone back and forth 7 times. Who does that? On one manuscript, back forth, do it this way. This I've
Wow.
offer some help just to make sure that it comes into shape. It's useful. I told the ENC, this is a very useful paper. It's great, but they just, like, they didn't get it right.
Wow.
Let's just keep working with them. So keep working, keep going back and forth, keep working. I've done that on a number of occasions, because I believe journals should actively mentor authors, not just reject their manuscripts. And so there's need for all that. So when this is our vision, when African journals become places where clinicians, practitioners, policymakers, trainees, they actually look to them for guidance. And this just stops being academic output for my promotion, but becomes a tool by which we can change systems. So there's a lot that goes into it. Even the authors ourselves, we have to begin to strategically select journals. That's how things begin to change. Editors need to start thinking about mentoring individuals. We need to think more strongly about implementation science and things that create change. And we were having a conversation at my university recently, strategic planning, and looking at the work that we had done. And one of the things we came to was that there is need for us to have policy, some policy brief or policy statement, something that actions every single thing that we set out. Everything that we set out. And it's pretty easy, really, to just think about how can it translate. So, and we've been trying to do that. Did a bunch of work in Nigeria, North Central Nigeria, looking at surgical readiness, anesthesia readiness, all that. And at the end, the key output is not a publication. Publications will come, but the key output is documentation that went to the Ministry of Health to say, hey, this is what we. And I remember very clearly one of the messages that came from the ministry. They said, when we were just going into research, and it's African researchers, isn't it? We're just going into research across the state, and they said many people come and receive permission for research, but we never see what they do. That's what the Ministry of Health said. They said, we never see what they do. She said, I hope you will bring the results back to us. That was very
Wow.
direct. And so I think that's the same question we need to begin to ask ourselves, so that we move things from these journals to becoming tools of. By all means, publish. Let's keep it on record. Let's increase. Let's even put our work in places where it can be seen. But let's be sure that it's really relevant to those places, and it's relevant to where we are. Over.
Yeah.
Lots to talk
I
about.
love that. Yeah, no, you mentioned the last point, especially you mentioned about the Minister of Health. I think I was thinking about it while you were talking, because they get tired of it, because they see someone come in, talking hot shot, and then they're nowhere to be found. But I just want to hear your take on this. Who is actually responsible for that? If the Ministry of Health is, as a ministry, it needs to have a guidance, or a protocol, or some sort of framework where people can go do research that is safe, obviously, make sure patients are informed about it, and a whole bunch of things that goes into the ethics and moral of conducting research, so good clinical practices and things like
Yeah.
that. So, as isn't that supposed to be the responsible body to actually follow through and see the researchers of what they have done, and the data that they gathered, and what impact it has? Don't you think so? Why are we shifting the responsibility to the researcher? What do you think?
Yeah. I think that there is a moral framework and an ethical framework in which every researcher should not rape a community and then get away with it. Right? So that's it's a moral thing, it's an ethical thing. But then there is a framework. I absolutely agree with you that there is a framework around which it helps the researcher to be able to do the right thing. But I think that a lot of this comes as a result of integrity. Like, this is you. Somebody invited you into their home. You collected data and information from them. And then, like that's it. So I think that for us, it's as researchers, global surgery researchers, it's an issue of ethics. It's an issue of equity. But then there are frameworks that can help. And somewhere like Rwanda has gotten it right. You can't just waltz into the country and then just collect data and then waltz out. You have to go through process, and they're reporting frameworks, and you're monitored, right? Unlike some other systems where you can come in, do all sorts of things, there's no unified thought around it. Data is not, we're not, data is the new gold, right? So in Rwanda, we're not careless with data. You can't just come in and do it. But some other places, you can come in, you take the data, you do whatever you want to do, as it were. So I
Yeah.
think governments have to think about these frameworks. In IMB Partners in Health, the overarching institution, organization with which I work, there is actually within Rwanda, there's what is called the Inshuti Mubuzima Research Committee. When you are collecting data, before you put out output, it goes through the committee. They look at it. Is this proper? Is this really representative? Is this adequate? They look at it. They didn't participate in your research, but they check it out. When you're about to go in, you get permissions. So I think we need to think about such frameworks to help our researchers. But even if you or I, as a researcher, enter a place where such frameworks don't exist, it would be a moral imperative for us to do the right thing, right? So I think that's what I'm talking about. We can be helped, but let that weigh upon our judgment that there is an appropriate way to go about things, so that we're not just walking into places and raping them of knowledge and then going and disappearing without
Yeah.
establishing relationships and things that would be helpful for the community, or taking back our results to help and assist others. Over.
100%, couldn't agree more. Okay, there is so much to talk about here. My mind is blowing up with questions right now, but I'm not gonna do that. So let's go to the other topic that you are obviously very attached to. UGHE. Okay, so that's your institution. And how did the University of Global Health Equity change the surgical training in sub-Saharan Africa? Because we know certain things that take place, but you have insider information. So how did it change surgical training, and what innovations have been integrated that have significantly changed the surgical education in that institution?
Thank you. I think that's the stuff of a PhD. You could you could actually frame that around that. But I think that the entire ethos of the organization, that's framed around social medicine constructs like accompaniment, like expert mercy, like things that are not the regular way the entire foundation of surgical training that's based on strong humanities, liberal arts, etc. And then before eventually people get to clinical care, African history, things like that. It really introduces an institution that is not conventional. Our students end up with 2 degrees. They end up with a master's in global health delivery, some of whom are already tilting to a global surgery track already, and then they end up with an MBBS at the undergraduate level. So at undergraduate level, for instance, we sat down and said, what does a day one general practitioner, you just GP, not a specialist, if you walk into a district facility and you are the only surgeon, you've got to do surgery, you've got to care, what do you need to know? So we did a Delphi across North, South, East, West Africa, and got experts to speak, including general practitioners who had been greater than 5 years, surgical care providers that had been embedded in the region for more than 5 years, etc. So they brought focus to say this is what we need, and prioritized surgical training, um, procedures, knowledge base, etc. Then we took it to a focused discussion. We had like 45 people in a room, experts of all sorts, including people who are not core surgeons but are doing surgery and are in these very remote locations. And the question was, do we agree? Had a consensus conference, had a Delphi, and we identified what we should be teaching, what the African GP in a medical school, as soon as they get to a district facility, should know on day one. We also did some other work, comparing expectations, comparing what was missing for those that were already there. So that actually formed the foundation of our training. That in itself is an innovation, because most times we cut and paste. Honestly, many institutions have seen curricula. I looked at so many curricula. We looked at so many curricula that we just take this and then we want to create this medical. Then we draw things. What is useful for Africa? That's the question we were asking. And then, so what we teach. That's the first innovation. What we teach is there. Our students are doing. They just finished a boot camp. And you'll be surprised that medical students are learning to suture, they're learning to do anastomosis one way or the other, learning to fix a hernia, learning to do a C-section and all that very actively, deliberately, so that they can at least manage individuals that come to them at these sites. So that's what we teach. Now, how we teach, we use the partnership-based model, and other people are taking this up because we realize that we don't have it all. I mean, for both undergraduate, postgraduate teaching, even the residency now, it's like the world is coming to support teaching. And so we have a statement that our curriculum is not just our own. It's open. Anybody can take it and use it. And also our teaching is not just our own. We have friends from multiple institutions within Africa, outside Africa, that come to teach. Some of them teach virtually. Some of them we bring them so that they teach. And then where we teach to, we don't, you see, it's easy for people to move to a tertiary facility, see all the filtered cases, and they just see maybe the hernias that are highly complicated. That's not what they will be seeing when they're in practice as soon as they come in. So we move them from an elite institution and move them to a district hospital or a level 2 teaching hospital, and they do their rotations at those sites. So they're seeing the raw disease that comes in from the community. They're seeing the epidemiology as it is. They're seeing the CAs that are delayed as they're coming in from that site, not those that have had 3-4 surgeries and then they're moving up to very hyper specialized surgical care. So kind of using that model, like the COSEXA-based district hospital training model, we have done that as an innovation. Then who teaches? Right? I've talked about multiple people coming in to teach, but our experts also are cognizant of systems when they're teaching. So they teach with, I mean, my students at some point, the Masters in Global Health Delivery students, even the undergraduate students, they follow a patient home. They go to the person's house and go and see, how does this person live? Right? Does this person really have them? You walk, you walk uphill, and you will be surprised how far your patients walk to come to see you. So next time when somebody comes in and says, "Why are you just coming?" you kind of have an idea that this was a 2-hour walk to this place, or you just carelessly write a prescription for some investigation that may not really necessary, but yeah, just go do this. you need to know what the situation or circumstance of that patient is. And then we've kind of integrated this knowledge over the years, and they're brought to this place. Our residency, we teach people to teach. It's another innovation, because our assumption, and I'm sure this happened to you in residency, when you finish residency, you're just like, teach, okay, start out this unit. So all the residents are coming in, and then you're just teaching them. But have you properly been taught pedagogy? Have you been taught how to engage, how to? So we've incorporated this. But non-technical skills are also strongly missing. From undergraduate curricula, we start to teach non-technical skills of communication, teamwork, decision making, situation awareness, all of that. Next week, by God's grace, we'll be teaching. We're doing an orientation for some residents. We have 2 days of teaching on the things that you cannot articulate, non-technical skills for surgery, right? So inclusion of those things. Then the technology, with what we teach, we are very high on technology simulation. That's like the core. You don't have to do it on a patient first. You probably should be. We're fixing fractures on simulation. We're doing chest tube insertion on simulation. We're doing, even those that are just coming in 400 level first exposure, they were doing chest tubes in the last week, because you do this out. You start this out on simulation, and we have lots of things that help us with that. Decision making. We use some gamification for decision making, so that surgical decision making is at another level for these individuals. There's the Entrust platform. We were helpful in being the first institution that turned it to knowledge for training, not just for an examination, but for training. And it's been taken from us to other subspecialties, other locations. So I think that technology aspect, we have a world-class simulation lab, has been another thing that has driven. But I think overarching is that Partners in Health UGHE ethos of equity that we have put into the curricula that has driven it. So we have a few frameworks that we have innovated, that are specific frameworks for education, for teaching, for training, district hospital teaching framework. We've presented it globally, where we're trying to remind people that it's not just the OR. I mean, there's a lot more outside that we have to think through. Over.
Amazing. This is just the perfect example of how data can translate into something completely applicable, beneficial, that has long-term impact, right? So I that is very impressive. I mean, I've always been impressed by UGHE, and obviously, it has built its reputation. So which is a good thing, and I hope a lot of other institutions, like you said, would learn from the curriculum that you guys use and try to apply it. Although certain things you need partnerships for, but I love you mentioned when you talked about innovation, people would jump to technology, but you talked about soft skills like pedagogy, non-technical surgical skills, and things like that, right? Which these are the things that actually carry a system through, because technology changes, but
Mm,
mindsets that have good foundation, those are the things that really keep the progress going. So I love that. You mentioned collaboration, which was very crucial in what UGHD has been able to achieve.
yeah.
But what is the collaboration that you see across institutions or in across the continent of Africa? And what has been the role of, you're involved in the Pan African Surgical Healthcare Forum. So what's the role of such forums, and what can, well, I guess, how can we do it better when it comes
Mm,
to cross continental collaboration?
yeah. I think, thank you so much, Ananya, for that thought. And I think we need to start by understanding that no single institution can fix surgical inequity. Maybe some have tried, but no single institution can do that. And for a long time, we've been focused on North-South collaboration, with its challenges. Any collaboration has challenges, but sometimes there's inherent power imbalances that we begin to see. There are interests that may not be spread out. It's the human condition. We have our own, but at the end, if we want to learn faster, if we want to avoid duplication, if we want to speak with a unified voice, then we have to start to think about collaboration to address workforce challenges, financing gaps, training inequities, and things like that. And that's what we saw with first the West Africa College of Surgeons bringing together surgical care across that whole subcontinent, as it were, and then began to see it with COSEXA crossing across East Central Southern Africa. Um, I think even if it's not a named organization, we need to begin to strengthen those South-South collaborations, begin to learn from each other. And so a group of individuals came together and were thinking about this problem and think about global surgical care and the road to 2030, etc. And one thing led to the other. Ministries of Health took the leadership. Minister of Health, Honorable Minister of Health of Rwanda, eventually the Minister of Health of Her Excellency, Minister of Health of Ethiopia, Honorable Mekdes. They began to take leadership. Minister of Health of Lesotho, and brought together African member states, really thinking about surgical care. So the first convening was, and this was misunderstood, was misread by a lot of our friends and colleagues. We said, no way. People wanted to come in from the global north and from around, but we said, no, let's just create a space that African ministries of health can speak to each other without undue influence. So one or two funders, so coming in, you are not influencing this, you are aware. And then we had to say no to a number of people and brought them together to say, okay, this concept of national surgical healthcare planning, population levels, is it necessary? Do you really want it? Okay, if you want it, how do you think it should be done best? And there was a lot of conversation. People said this, we've written around the whole process and how they felt things should change and be suited to Africa. We want to think about our communities, national surgical healthcare planning, as it were, the raw cycles. Don't incorporate communities, don't incorporate. There's a lot of, let's get this facility ready. It is the service end. What of the user end? People were coming up with the ideas. They were like, oh, national surgical healthcare planning does not make a country work. What of the implementation? That's the elephant in the room. So how going to, so there was lots of that thought. There's lots of that. And they began to organize themselves. We were like midwives within that. The secretariat still sits with the University of Global Health Equity, but the leadership is square on the shoulders of African governments, right? So that kind of thing, thinking together, peer knowledge, peer learning. Last year, people were in Ethiopia just thinking about how do we deal with our workforce shortages, learning from countries like Rwanda, right? Learning from countries that are doing, Rwanda is doing a 4x4. Next 4 years, all specialties, all that, we want them quadrupled. Wow. So how do you do that? So those people are learning from each other. And sharing their experience. We brought in ministries of finance because we just talk about healthcare. It's funded. So we brought in those ministries. They were talking about how they raise funding, what to do next, etc. So those are the kind of things, and it's not just PASHeF. I'm sure there are a number of other groups. We also involved with the colleges of medicine, the consortium of medical colleges across Africa, COMSA. Also started out with UGHE as a midwife. But the idea is to bring together Africa. It's a critical role. It has a critical role as a neutral convening space. Nobody's saying, oh, this is what we're pushing on people. But the African continent can decide. You can bring together ministries, surgical colleges, academia, fund. It's not about parallel structures. It's about alignment, bringing people together. But the real value of this is taking learnings from one another and pushing them forward as policy signals, as a workforce planning conversations where one country can send to, again, I'm using these countries because I'm close there. Rwanda sends people to Ethiopia to get surgical training, and then they come back to expand their workforce, things like that. So that kind of thing, financing discussions at regional, national levels, how can we as a consortium get resources? People respect Africa when we stand together more, right? So united, that kind of, I think that there's a limitless opportunities for us to be better when we work together. So the role of collaboration is the future. That's it. the role of collaboration is the future. If we don't work together, then we actually are mortgaging the future. Everybody's doing their own little thing in the corner. We're multiplying resources, everybody focusing on the same problem in parallel, when we could, as a consortium, work on it together. But Africa will, and I can say this as a futurist, Africa will not survive if we keep doing our things in our corner. But when we band together, we begin to see the best coming out of this continent. And that's the idea behind the Pan African Surgical Healthcare Forum. It was Ketima Ifru that was saying that we need to begin to discuss African problems, African solutions to African problems, rather than sit down and wait for some donor from the global north to solve the problem. And that's the framework with which we're thinking through this. It's a much more open meeting now. People are coming in, but the agenda has been set by Africa for Africa. Over.
Wow, amazing. I'm looking forward to see what it's gonna materialize to, because that is really the solution. We just need to stop looking out other sources outside of the continent for our solutions, because the systems are so different, right? Even though everyone has started somewhere, right? Even the global north had to start from where Africa is and has to go through each and every process to get to where they've gotten to. But still, it's like labor pain, right? Once you go through it, you forget about
I
it.
know nothing about that.
I'm telling you, take my words. So it's something like that. So, and people come with their own agendas, especially in the global north. We have to be honest that a lot of things are related to money, and
Yeah.
it's business. So
Mhm.
it's very hard to really solve our problems with the solutions that the north brings. There are great collaborators, like you mentioned, always, but there are also other um, aspects that cannot be ignored, that have may not necessarily have the best impact on the plans that Africa would have for its own population. So
And I
go ahead, go
no,
ahead.
wanted to chip in that, true partnership does not have a giver and a receiver, as it were, right? There's supposed to be some mutuality. So if we're sitting out there then stretching our hands and somebody's donating, that's not truly a partnership. So what's the value that Africa is bringing to the table is the question we should ask. And there's a lot of value.
Hey.
It may just not be in the same terms, right? So we
Mhm.
must we must learn partnership, and we should not reinforce structures that create this kind of giver receiver thing. So if people are coming to partner, by all means, there's that mutuality you're working on. It's not something that's extractive. It's there are many frameworks by which we look at equity in these kind of spaces. So I think we need to be very strategic and think about it in that way. And Africa needs to begin to wake up and look for solutions that are right there. We've got, look at you, brilliant minds, brilliant mind. Lots of work and thought that you're doing. So many other people within these circles who have solutions. We need to begin to make space for them to operate and space for them to grow. My thoughts.
Yeah,
Thank you.
100% agree. Oh, that's fantastic. So what about global surgery advocacy? Because we see a lot of people, like you said, your institution also provides a training program in global surgery. But when it comes to the advocacy work, because sometimes knowing something and, like you
Mm,
said, implementing it are two different things, right? It's a different skill, it's a different mindset, it's a different level of networking, collaboration, and so many other things. Um,
mm.
so in your view, what has been done so far that you think is significant through the global surgery advocacy, especially in the African lens? And I want to ask you this because when we took the course at University of Cape Town, which was a privilege to have participated in that along with people like you guys, because I was just learning so much from the conversations we were having. But um, there were some certain things that I have seen for myself and kept as a reminder. But I want to hear your view. How do you see the representation of African countries in global spaces like the World Health Assembly and so many more, actually?
Yeah, you know, there's a lot of politics in this question. but
That's why I'm
the
asking you.
but okay, let me narrow down to global surgery. Global surgery and its advocacy has matured significantly. For a long time, our advocacy was just like, oh, there are 5 million people who do not have access, or 5 billion people who do not have access to surgery. So we've painted global surgery in terms of advocacy in a as a needs-based thing, right? Unmet need. But now global surgery advocacy is shifted. Now, the overwhelming majority are speaking of it as an essential component of universal healthcare and bringing it as a solution to the entire system. So, what happens during COVID? COVID, you know, their lack of ventilators. So what they do, they go to the ORs, get these anesthesia machines, use them as ventilators. Or who are the specialists that can help us with this again? Oh, anesthesiology. So this is a component of surgery. Who are the physicians we can make? What are the wards we can transform? Or where's the oxygen we're going to use? We go to the OR. So if somebody had a strong surgical system, with the oxygen, with the ventilators, with the ICUs, with everything, they would have been prepared for a pandemic. So we've positioned surgical care as the foundation of pandemic preparedness. We've positioned it as the foundation for the rest of the system. If you can make sure there's oxygen for an OR, then there's going to be oxygen on the wards. If you can make sure you have enough of XYZ that strengthens the surgical system, we're actually strengthening. So thought has begun to shift from just saying, oh, sorry, poor us, just have mercy on us kind of thing, to, hey, we're offering a solution. And national surgical obstetric anesthesia plans, whatever people decide to call it, doesn't really matter. National surgical policy, national surgical healthcare plans, they add in the nursing components, etc. What matters is people starting to plan for their country's surgical care. No, and I can't take the argument that you don't plan for something and you want it to happen, right? In whatever way, you can put in another document, do it in another, but you say we don't plan for surgical care, healthcare, and then you are complaining that surgical healthcare is not happening at national level. And so advocacy has moved to this level. Part of what's happening at PASHeF is countries are supporting each other. So Somalia is being supported now by other people within PASHeF network. Liberia is being supported within. They are building up. Sierra Leone, based on support and a lot of the work they've done, they just launched their national surgical plan. We're saying plan for it. Implementation is important. That's what African member states say. But if you don't even have a plan, someone said you fail to plan, you've planned to fail. Proper preparation prevents poor performance. Is that P-ism? So I think that it's changing. It's changing. And programs like the Global Surgery Advocacy Fellowship, the Global Surgery Advocacy Program that are run out of UGHE is doing that. We've got introduction of, for just a few wins, we've got introduction of laparoscopic surgery into the Ghana College of Physicians and Surgeons by one of our trainees. We've got respectful maternity care that started taking a turn for the better in Rwanda as a result of that. We've got patient voices that now were being heard by one of our young ones, our colleagues that was working around surgery voices, just what matters to the patients. We've got people who, for the first time, there's a sarcoma trust that's been set up in Kenya as a result of these voices. There's somebody who's really advocating for young women surgeons in Kenya as a result of so. And what we did was, along with our partners, Operation Smile and Inkafu Policy Institute, again thinking outside the box, bringing in a policy institute to work. We get human rights lawyers. Surgeons can't teach you advocacy in the same way. Human rights lawyers, people who are fighting for HIV, fighting for women's rights, right? So people who are used to this terrain, they mentor our global surgery. So I think things are changing. We're saying we can't do it alone. We're now reaching out to others. We've got a policy to practice workshop by Smile Train, UGHE, PASHeF within that space, where people from 15 countries also are carrying these plans and implementing them. So I think that a lot is changing. However, African representation in global forums like the World Health Assembly, etc., it remains limited, not just in numbers. We're not talking about numbers. We're talking of agenda setting power. Who sets the agenda, right? So just being there doesn't matter. I take a plane. I walk into Geneva. I play around some side meetings. I mean, agenda setting power is what we're talking about. Too often, Africa is discussed rather than heard. And, you know, now, but again, I want to say something is changing. What's changing is the rise of African surgeon advocates, others that are within this circle who are fluent in policy language. They know something about economics, they know something about diplomacy, not just clinical evidence. And so I think that there is hope. There still may be a lot, like our surgical representation at the WHO is still pretty challenging, But I know that we're seeing. You see many coming out of Cape Town, some coming out of Rwanda, some coming out of the West Africa. People are getting more aware and better, better prepared for these spaces. But like one of our mutual friends and colleagues would say, so now you are giving the table. Now you're sitting at the table. What are you going to do with the table? You're fighting to be on the table. Now you get the opportunity to be there. So what are you going to do with it? So I think it's that preparedness we're beginning to see more and more.
Yeah.
One of
I was gonna say for
I
a
think
very
I
long
think we should.
time the goal was to get to the table. That was where it ended. Yeah. All right, go ahead. I'm sorry. I just that came to my mind, and I'm like, he's right. The goal was just to get to the table, but we never thought about what do we do after we get to the table? What are we carrying with us? What do we want to impact after getting to the table? Are we just grabbing coffee and just being there just to be there? So yeah.
Having a sip and talking about the problems of Africa, you know. So, but I think that there's that rise of African surgeon advocates, and some of them don't look like. Again, I want to say this: that in our spaces, we should respect that, right? Because sometimes we just look at someone and say, "Oh, this one is just a policy person. He's not really a surgeon." We have to respect that. That's the thing. We have to respect that we will work in different spaces, and if we get this right, then your work is a lot easier. And who better to take that policy space or that advocacy space than somebody who's familiar with things that go on at the ground? Many people who are representing in those spaces have no idea about what happens with surgery, no idea, and the myths are still fresh in their minds. Like, oh, surgery is too
Mm-hmm.
expensive. Not much. Why should I invest in an OR with an anesthesiologist and when I could do a bed net or do something that will get me elected in the next 2 years? So these things are there. But what is happening is people are beginning to understand the language, the spaces in global surgery advocacy is called the framing. People are framing things appropriately. Jeremy Schiffman's ideas. There's now an appropriate framing that is coming up, and I think that we should encourage, especially more young people, to begin to go into those spaces. And with the rise of global surgery programs, I think that's where we're getting to. Not everybody who graduates from a global surgery program will work in global surgery. They'll go back to global health spaces. They'll go back to some of this, but we are raising advocates in those spaces that will insist with the Ministry of Health or the Minister of Health and say, oh, become Minister of Health and insist that surgical care is on the agenda. Over.
Yeah. Um, so you talked about skills, like you said, as a surgeon, you might obviously you're good at a certain skill because you've been training in that, but maybe you need to learn from somebody else, like you said, a human rights activist, somebody who's out there who knows how to make their voice heard. Because as a surgeon, I don't want to admit it, but we can be a bit egotistical, and we're like, couple of words and everybody should fall in line. But it's a whole different game, uh, if you really want to make a greater impact or influence in a global setting. So we still got to learn other skills as well. And like you said, it's always better for my friend who I worked shoulder to shoulder to go and argue on my behalf to bring about policy change than somebody who has never stepped into the theater, who doesn't understand what it takes to be any professional within that theater setting. Could be a nurse, could be on stage. Even being a janitor in a theater is different than being a janitor in an office, right? So even that level of understanding is very important to affect change, because collaboration, that's really what keeps standing out for me when I think about global surgery advocacy, or anything of such sort, because everyone has a role. There's no role that's too small, no role that's too big. We are very interdependent on each other. So that's really what stands out to me. But talking about skills, this new era of rapidly advancing technology and, globalization as we've never seen it before, including, the now inevitable AI integration into healthcare. So, what skills do you think? And this might not be your area of expertise, but I just want to hear your opinion. What skills must a surgeon have now to better prepare ourselves in such an environment?
Yeah, just a caveat. I am not a tech geek, but I've done some work around AI. We have a scoping review just looking at machine learning in surgery across low middle income countries settings, and finding out where it's been used here and there. We presented that in a number of fora, and really seeing the need. I've also worked with one of my mentors during my fellowship. One of my fellowships was Bethany Head Gothia, who were just doing using AI. Just take a picture. That was before the AI explosion, right? Take a picture of a wound, you send it up, AI tells you this infected, this not infected, right? And if the patient is infected, we found 70% of catastrophic health expenditure was as a result of people coming back for follow-up following their C-sections. So what to do about it? Can someone not just go out from house to house in the community health worker? Not necessarily. Once you see that there's an issue, then you send the patient back. If there's nothing, why spend that money, right? So we did a lot of that work and spent a long time looking at images and turning things. So with that in the research space, I've done some work around that and technology. I'm also part of a group that is trying to shorten the amount of time it takes for ambulances to locate people in Rwanda and then get them to a particular facility. So there's this destination decision support algorithm that we're working within the space of with partners in Birmingham and University of Rwanda, etc. So I think data literacy and digital literacy, simple, like digital data literacy. What does this mean? What do these metrics mean? What we need to know. And so we can't sit in the or behind desk or a consulting desk and not start to think about. I've been in this clinic for the past 10 years. So who are the people I'm seeing? Why am I seeing this way? What are the associations that are there? So that digital data literacy, the surgeon of today must be technologically literate, not necessarily a coder, but somebody who understands what data means, and then their AI decision support tools is basic as AI decision support tools, digital health platforms, those kind of things. You just can't run away from it. You'll be left behind if you do. Someone said that AI will not take over the role of the surgeon, but the surgeon who knows how to use AI will take over the role of the surgeon. So that's where we're going. Now, the second thought is what we've been talking about. You see, the other skill we need is systems thinking. We must know how referrals work, financing work, supply chain work. workforce policies, how do they affect outcomes? Those kind of systems level thinking is another skill. And whether that's connected with technology or not, because data can also drive that, is another case. But we need to begin to think beyond where we are. In fact, it comes naturally, because as you rise, the more time you spend, the more effective you are in the OR. Somebody notices you and says, can you come and lead this department? Can you come? And then you get to a place where you have to think systems. But some of us are still thinking in that way. Then I'm very passionate about this non-technical skills for surgery. Those are the future. And if you don't get them, you will be left behind. Because Africa is changing. It's no longer, I remember during residency, I'm standing on the podium and somebody's just annoyed and saying abusive things, and not just like washing you down. Why did you talk like that? Are you married? And you say yes. He said yes, that's why you're too distracted.
If you're not married, that's why.
If you say you're not married, you say yes, that's why you're too distracted. It's the same thing. So but the thing is, that thought, the Hippocratic means of teaching and just slamming down people, is changing. It's not today's world. So we're talking communication, how you speak with nurses. We spend time sitting in operating rooms in West Africa, just watching the interaction of people, and you'll be surprised what you see, right? And then we put that together in knots with which we taught in a particular country. We asked people critical incident interviews, just asking them, when this patient almost died, what happened? When this patient eventually did die, what happened? And the dynamics are the same. The data tells us 50% of adverse events in the operating room are as a result of non-technical skills, not what you are taught necessarily during residency. So if we don't get that right, we miss a lot. We miss out on a lot. Our patients are not safer. And so we're working with communities we've taught this year, Malawi, at Bujumbura, where we're teaching from place to place. We're going to the West Africa College of Surgeons in the next by February, somewhere in February, to just teach these things that we believe surgeons need for the future. So they're not soft skills. People talk about them as soft skills. No, they are core competencies, and we have to think about integrating them, learning them, using them. So some of us gain these skills by just being privileged to be under a good mentor, right? But some are not. You're operating with somebody who still in this day and age throws instruments at people. Man, what? Come on, right? So, so will you pick up that? And then we feel this is the way to relate with the nurses. This is the way to relate with people. So I think that not a leadership. How do you lead? Teamwork, communication. How do you take decisions? There's a science of decision making. There's a science of situation awareness, being aware of what's going on around you, right? There's a science of management of cognitive load, and all that. Those are skills that people need to pick up. Then, and finally, I think this ethical reasoning in AI use, in technology use, because we're getting to a point where if we're not careful and we don't draw boundaries, the ethics of AI use is going to be something else. There are many decisions that are being taken already, many things that are being done. So it may not seem like a core skill in terms of coding, but also the skill of being able to discern: should I not? Is this appropriate? Is this not appropriate? Should this be used? Should not? It's not. So those being ethical stewards of I think it's another thing. Who benefits from this, for instance, and who is excluded? Is there bias here? I was sitting with a friend in the Silicon Valley area, and he just brought out something. I said, "Put your hand on this. Put your hand." I did. Nothing happens, and then he puts his hand, and it lights up, right? And he spent a whole year working with a team of healthcare sciences from a very big, well-named company to develop this product. The entire data set they used was Caucasian. They did not use any, and it was showing me that this cannot work for you, but it can work for me. And at the end, they were like, "Oh no, oh no." Right? So through much development, much resources spent, etc. But at the end, it was the bias was built into that. So data that's used to train AI is bad. So you have to ask yourself the question: who's being left behind? Who's being left? So that discernment and that knowing who is excluded, how can we address this bias? Then at the end, I think that it's this mindset of continuous learning, adaptability, just keeping going. I had a mentor who kind of refreshed and got a PhD again at that stage in his life. I started asking myself questions. Yeah, you got to keep going. So that continuous learning, it will define relevance in this era. I think those are the things that will define the future. Because the landscape is changing so fast. Even the AI we think we knew yesterday is changing so
Oh
fast.
yeah. And those
Learning.
are the ones that are been made public, because yeah, the ones we're not seeing are way advanced than what we're seeing. So yeah, it's a whole thing, but there's a lot of concern. And I think, like you said, Africans, especially those, because we're talking about healthcare, but no other areas excluded, we need to think about how do we take ownership of our own data in this day and age, because like you said, data is where the value is now. We human beings, I mean, it has, you have a theology background. I believe in God, so we know that we have always been the most valuable, um what do you call it, life on earth, you know what I mean? So we've transitioned from gold and diamonds and everything being high value. Now humans are high value, the data of every human is high value. So we're coming into that area. It has become reality. It's no more sci-fi or whatever. So we need to think ahead. We need to think 20 years, 30 years, 100 years from now, because things are advancing so quickly. We have to take ownership of our data, about data security, a whole bunch of stuff, right? Representation and all things like that. So it's just, I'm excited about it, but I'm also very worried about certain things.
That's aren't we all?
Yeah. So finally, I mean, we talked about a lot of things, and you're a brilliant mind. I always enjoy talking to you, but I want to know what you want to see in the future, whether it's just something general or maybe something more specific to your own journey and path. um, what do you want to see in the next 50, 30 years in the healthcare system in Africa and globally, whether it's your personal impact or whether it's just something general?
Tough question. But let me preface it this way: there's a leadership expert that I listen to, follow his podcast, Craig Groeschel, and along his leadership journey, he taught one lesson, among many others, but one lesson. He said things change so fast that what you think is a vision for the next 20 years, 30 years, 40 years, just give yourself a little time. It's likely to change. He said all his strategic plans, he never got there. Something would just change. And the greatest places of influence and value for him, where he was at the time when he's speaking, he said it was being prepared for opportunities that came in advance. So he said, prepare. He says, plan lightly, prepare thoroughly. Thoroughly. In other words, an opportunity will come in the vision that you have that may expand that and blow it away. So I'm prefacing this. You say, in the next 3 years, this may change. This may change. However, I want to see African health systems where the place of birth no longer determines your access to safe surgery, where surgery is normalized within primary healthcare, secondary healthcare, not concentrated to just the urban tertiary areas, places where everyone can have that access. Then I'm seeing African institutions leading the global research agendas. They're training their own specialists, right? They're exporting innovation rather than importing dependency. That's what I'm seeing. I'm seeing where, again, this is a vision. It's not there yet. We're not seeing it there. In fact, we've not started working on it. But I'm seeing where technology, including AI, is closing gaps rather than widening them. Because we're seeing some things widening them. Then generally, I think I'm seeing us moving towards shared accountability, where we're not just talking about equity, but we're actually measuring those outcomes, because the talent is there, the systems are, but we're moving in that direction. The commitment is there. There are lots of people who want to get this right. So what I'm seeing in the future is not just about Africa catching up. During residency, one of my consultants said, and I never forgot, he said Africa is 30 years behind the world in terms of surgery. This was his assumption, just looking at it, because then, laparoscopic surgery was a big deal here when people had moved to robotic surgery, right? And now they're going to autonomous surgeries and things like that. So I'm seeing a future where Africa is not just catching up, but is actually leading, but leading differently, with equity, purpose, great context, all that at the center. So those would be some thoughts, just looking at the future. But as with many things, the future really depends on what we do with it today. Right? If you check the vision of almost every global surgery institution, this is what we're seeing. This is what we're seeing. But how we get there, or whether we stand up to do what we need to do to get there, is a totally different kettle of fish. Right. So those are those are my thoughts, and that's what I envision for the future.
Those is great. I mean, I hope it happens. Because I know it's good if it happens, and we're all gonna benefit. So I really do hope it happens. And like you
I,
said, we all have to, huh?
I said I love the hope. What
Yes, that's all we have, right?
Paul called it, and Jim Kim also has used that phrase. The framing is the imperative of hope. He describes hope as a moral imperative. We have to hope. We can't
You
just throw
have
out.
to. I mean, look, that's why even life, when you're outside of the profession, just life, right? You do
Mm,
something today hoping that you will be there tomorrow, you'll be here tomorrow, but nothing is guaranteed, right? When we go to bed, we're not sure if our eyes going to open the next day, but yet we still, so hope is really what makes humans go.
mm.
So yeah, so I hope it does happen. And yeah, thank you for coming on. There are so many things I want to talk to you about. I'm definitely going to have you back, and we're going to dive deep into more difficult conversations, because that's what we're about, having difficult conversations. um and yeah, and I mean, I hope and I pray that you succeed in whatever you're doing. I know what you're doing. You have a good heart, your mind is in the right place, and I hope you succeed and all the dreams and hopes that you have for African healthcare materialize.
Thank you so much, Ananya, and thank you for bringing me on. I really appreciate it, and I respect and honor the work that you're doing. Thank you so much for all you do.
Thank you.